also participating in our seminar series. We can start.
Thank you, Aminat, for the invitation and the great introduction. And thank you for the opportunity to present in this evening. Well, I should say this morning in Australia. It's 8 p.m. here in Canada. So thank you for the invitation. Today I'm going to present to you some strategies we're trying to put in place in data science, and that was put forward a lot during this last pandemic. And this is a large collaborative project that we've been working on way before the COVID pandemic, but that was accelerated in the last few years. Just some housekeeping. So during my talk, if you have questions, please don't hesitate to send into the chat. I will try to follow on the other screen. I think I'm hearing a lot of background voice. Is it, am I alone? No, okay, great. So if you have questions, please don't hesitate to send the chat box. I will try to follow, or I will take questions at the end. So first of all, more important, what I'm going to present to you is not the work of one person, but of a large collaborative. And on this slide that I've done a few weeks back is probably already outdated. So thanks to everyone. And I'd like to acknowledge, I cannot name everyone, but a big thanks to the whole team. Some disclosures. I have no private industry and disclosures to for this talk. However, I received funding from several public agencies, so all government of Canada or province of Quebec agencies or academic institutes have funding. So I think I received this invitation after this publication that was published last December 31 at 5 p.m. I did not know that was possible to publish at this time of the New Year's Eve. So it was an analytic paper we published in BMJ that highlighted some challenges and limitations that we faced when we wanted to use some new technologies such as AI when the pandemic hit. So I'm a clinician, I'm a critical care physician, but I also wear the hat of a data scientist when I'm not doing ICU and patient care. And my role when it's not a pandemic, where I spend most of the time in the hospital, is do clinical research to improve care. But when the pandemic hit and we tried to implement or literally help with these new technologies, including AI and machine learning, we realized that there was not much we were able to do in that context, and we had to fall back on traditional research and mostly expert opinion and the usual way we do medicine, in short. So why is that? We do present some piece of opinion in this paper, but today I'm going to present to you what we are putting in place now to, in the future, be better if we have another pandemic, hopefully not, but also for patient care in general. So as you know, when you are in the ICU, so this is one of our ICU room. The patient is in the center of the room, but data is everywhere around you. You have all these monitors and ventilators and pumps and machines. All of it is really focused on patient care, not really for research or data analytics or any of that. So how can we use it and can we do better than what we are doing right now? So I give you some examples of what is a patient in the ICU and all the data that is generated, that can be generated, be it at the bedside or blood banks or biomarkers or blood samples or even scheduling, administrative data, and in our hospital, even robots that deliver the drugs and medications. And so infinite amount of data is available to us. And when the pandemic hit, we were like, well, there's not much we can do with it. So can we do better? So what we have put together and what we identify is a need for access to information that is reliable, of quality, ideally standardized if at all possible. from several sources, diverse sources, but also from several jurisdictions, cities, provinces, and countries, to favor, if at all possible, diagnostic risk stratification, and in the case of COVID, specifically, identification of distinct clinical phenotypes, early warning systems, more efficient use of health system resources. And I will pass. You all know what to do with what we can do with more data. However, COVID-19 pandemic exposed several flaws in that, especially in the context of implementation of AI at the bedside. So for example, we have a very big challenge in data access. So we see it, but how do you access it in the context of research or even actual care of the patient? The data flow is not at all optimized for real-time analytics. There are a plethora of privacy and acceptability issues. The technologies, even the basic science, mathematics or biostatistics or computer science, algorithmic technologies are maybe not there to do what we need to do in a real care setting. It's often very slow to get access to the data or to the analytics itself. The costs are prohibitive. We are not always sure of the validity of the data, and more is always better. And sometimes it's not that easy to get a lot of data readily available. And one of the big challenge, and I kept one slide for this one, is generalization. So even if you manage to solve all of the things I mentioned since the beginning, how many models have you seen that were developed on chest X-rays or this data set that is open source, that when you get it, you try it on your patients in real data, it fails. So why is that? And can we do better? That's what we are trying to do. So we identified the need to create an adaptative platform that is ideally heterogeneous, so that we can, where we don't have to force a common technology to everyone, that can adapt to the different technologies and especially the different data sources that you can see, or philosophies of data management and so on. That allows on-site data extraction. And when I say on-site, I mean literally at the bedside. We don't want to have a nurse or research coordinator to go at the bedside and look at the monitor and then transcribe data, put it back in the database. And you know how this data flow that is not efficient. We want live data extraction at the bedside that can be managed as automatically as possible, that is really available for management, transformation, and analytics. I mentioned live probably 10 times since the beginning. That enables retrospective data extraction, but also prospective gathering of data that can adjust to new technologies, ideally open source. That allows also for central, distributed, and federated analytics strategies. I'll come back on that in a few minutes. So where we're at, we deployed, and we are still developing, a partnership between several health centers. So right now we have 8 big health centers encompassing more than 4 or 5 million patients, to establish an infrastructure to, if possible, standardize as much as we can, pull and make the best use of data. And for now, in patients suspected or tested for COVID-19, we are in the process of removing the COVID-19 filter to have access and in fact, be able to analyze all patients that are cared in those health centers. Of course, we are using this to do epidemiological research, but also to build predictive models and hopefully decision support tools. We have a website, CODA-19.com, where everything we are developing is open source and available. If you go right now, and not everything is the latest version, but we are in the process of releasing everything open source as we speak. I'll come back on the variant question in the chat in a few at the end. I will not go into details into this slide. I usually keep it to explain when I present in my country how we can do that legally. So just so you know, the legal aspects in the province of Quebec in Canada are among the most stringent that I know of. So we had to be very cognizant of the laws and ethics aspect. And that's why we took several technological decisions that if you dig deeper, you'll see, hey, why were they took so complicated routes to do what they're doing. So a lot of our decisions were because of privacy issues. So for example, believe it or not, we cannot just share data between health centers, even for care, without direct patient consent. So that's why we had to develop advanced federated analytics capacity. Let's talk about these capacities. So although I focused a lot on data access, pipeline, speed and quantity and validity and so on, everything is really privacy first data sharing architecture that enables the data analytics in three main ways. First way is centralized. So this is the usual way. You gather your data at each site or at each data set you want. You bring them on a central server or laptop or computer. You do all your data linkage and you do your analytics. We can do that, but when you don't have direct consent in our province, at least we cannot really do it. We also implemented a decentralized method that is some sort of meta-analysis. So you collect your data at each site, then you simply meta-analyze and provide estimates that are meta-analyzed. But we also deployed federated analytics strategy where in fact, there are two kinds of federated learning strategies that we are deploying. The first one is sample-based. So how it works is that each site shares same set of variables. It can be different. So a site can provide 100 database, one only 10, but everybody will provide the same kind of data. And the patients are considered to be independent at each site. So as if each site had a different patient. So as you see in the picture, patient 1, 2, 3, 4, say site 1, 5, 6, 7, 8, site 2, and so on. So it's also called homogeneous federated learning. So it's a client-server approach where each site, the client will participate in partial model training, and then we have a global model that is calculated server side. So, and then it's an iterative training process until completion and conversion. So until your model trains nothing more. So you train at site 1 and then at site 2 and site 3, and you go around like this until you cannot train anymore. I'll show you an example in a few minutes. So this is already implemented and working. So what we're working now is a second phase of federated platform development, where each site also shares the same set of patients. So as you know, across different institutions, the patient can move, can go at site A and site B and site C. So, so we have to also find a way to follow patient 1 to everywhere across the healthcare system. So this mode of learning is called also heterogeneous federated learning or feature-based, where you can complete, you can start with some data in site A, and then continue and get some more data in site B, and so on. This requires a more advanced privacy-preserving strategies with public, private keys and asynchronous keys, and I will skip the details for now. But this is currently what we're working right now to be able to add some more data. So for example, if you don't have death, then you could link to a death registry without even sharing that patient identity to complete and obtain the death status of your patient without direct data share. So more details, how can we do all of this? So I know that this is small, but what is really important at this stage is the colors. So on top, you have a site. It can be a hospital, can be a an area where you have some data sources that you're interested in. In the middle, you have your coordination hub, and at the bottom, you have your visualization layer. So the easiest part is the visualization layer, where you can monitor the health of your hub. You can do some query building and explore a little descriptively your metadata to know what's out there, what kind of data you have, and some basic descriptive statistics of your sites. You show you how we can use it in the context of COVID. And this is where you can send or receive the output of your learning models. We do have a coordination central hub that is used to link all the sites together and to know which site can communicate with which site, what kind of data they can communicate and how to communicate it in what format, and that will also do the data pooling if required. And this is where the security policies are implemented. But really where the fun, if I may say, happens is at the site level, where at each site we set up 3 zones. I call this, for the sake of this discussion, virtual machines, where you have 3 levels of security. You have a red, a yellow, and a green level. So in the red section, I will give you some details next slide. You have a staging area that contains private data and identifying data. This is in fact your hospital or your site. After that, you have an orange layer, orange VM, where we store, for the sake of research or data analytics, the anonymized or de-identified, depending on the needs, data. And then you have a computing node. This is called a green VM with no persistent data, where we deploy all the APIs we develop. So the learning API, the stats API, and science API. So all the data is gathered and collected and transformed in the red VM. So you start from patient data. Then we have some hash functions to de-identify and encrypt the data that is more sensitive, but still might be required for linkage with other data sources. Then we have a terminology layer where we convert everything in common terminologies such as low-ink, SNOMED, or other kind of resources that you know. And then everything is converted to the FHIR format, which is a common health. It's a common health format to communicate between electronic health records, to end up with a database or several databases, I must say, that contains data in a format that can be used commonly across sites when needed. So in the red VM, we implement all the required libraries to extract from administrative source system, clinical source system, operating room, diagnosis, labs, and we can link also custom sources of data such as biobanks or other research sources if needed and required for the project. Depending on the institutions, we are institutions where we connect to very well developed data lakes that already have an integration engine and data feeds that are already ready for extraction and analytics. But we have other sites that literally dump CSVs in a folder, and then we run cron jobs to clean everything and transform data so it can become analyzable. When we do all this magic, so this is really hardcore data science for the data scientists on the line. But at the end, we are able to end up with some common terminology, so we can use it remotely in a federated manner. That are stored in MinIO, which is S3 compatible storage system for binary imaging, pathology images, and waveform, and so on. But we also have a database that's basically a Postgres storage system that allows us to store all the other data that can be stored in file format for further analytics. When I say open source, for now, everything is open source except one layer, that is the 8-box layer, that is on top of what we call Firebase, that is a file management database. Reason we have this layer from this company is to speed up deployment. We needed to be to have some regulation layer, and this was already implemented, and we did not have the time and capacity to develop it ourselves. So this company 8-box does that. So, but it's not a sponsor. We do pay for to do that, to obtain their license. Sorry. And this is what the workflow looks like. So when you decide to send a query, you program it, and I'll show you an example into the central. You can be at any site. You program it. You can test it on synthetic data, and when you're satisfied with your code, you have several steps to follow. We have an API specification dictionary, API, sorry. But you basically prepare your data, then you wait because it can take some time to go around the site so the data is ready for analytics. Then you can send your model for training. Or if you already have a trained model, you can do the opposite. You can send your model at the site you want to validate your model and test it on real world data. So it requires for us the development of our own stats and learning API and site API to do all of this. All of it is open source and available online. Again, if the last working version is not right now available, but should be in the coming weeks, we're still working on some bugs. Everything again is really focused on privacy. So audit log, several authentication system, data security and deployment guide, code review committee, and a whole governance regarding privacy and security that we are currently updating, and soon in the process of obtaining an independent privacy and security audit. And that's the big idea on how it can work in the back end. So what can we do with that? And this is the last part of my presentation. I have some examples. So we start with basics visualization. So during the pandemic, our governments and decision makers, I don't know how it was in Australia, but in our country, nobody had any idea what was going on. Initially, they were literally asking us to count the beds and the sick patients, and just to send them an email and tell them how many patients we had with COVID. And then it got a little bit better with some custom alerts that some labs developed to warn the hospital policymakers. And now in the province, they are just getting better and getting the data almost real time. But with this kind of platform, so this is a screenshot I took like last spring during I don't remember, second or third wave in our province. So this is a view of 3 sites. I just show you this view because it's completely federated. So this one is meta-analytics. So no data sharing. And you can literally know the number of tests, number of new cases, number of deaths, and then you see the wave over time across the different hospitals. So this is a visualization. Of course, it's very simplistic, but it's a proof of concept of the kind of visualization we can do. We have what we are more proud now is the learning API. I say prototyping development phase. Sorry, it's outdated production by the end of the week, but it is in production now. So we now have this learning API where you have 3 steps to follow, where you prepare your data, you train, and then you have a validation step that are already implemented. So it's based on TensorFlow. So most of the the specifications supported by TensorFlow are supported by the platform. So this is an example. So I just hit play. So in the center, you see a box where we did enter the prepare request as per our API. So you select the variables you need, the format you want, and since you already know you already have a Fire dictionary and the resources you know, and you can query under your dashboard what data is available at each site, you can specify in your prepare request what you want. Once the data is ready, you can then code your model as you would in fact, literally you can connect a Jupyter Notebook to do it. Right now it's our dashboard, but we do have Jupyter Notebook connected. And then you send your train model. So as you see here, you see a live training of a model across. Here it's on 2 sites because for the sake of the video, we did not want it to be too long. Of course, the more sites, the more data, more time it can take to train. But it's always faster than waiting months or years to gather all this data. So it's not real time, but it's on the scale of how long it takes to train a model. So this one was very simple with def and 3 or 4 variables, but you see a little bit the idea. Oh, I have it 2 times. I'm sorry. And then for policymakers, you can do other fun stuff, such as this one, where you can do flow analytics. So here you have, well, it's a flow model. It's quite basic, but you see here each dot is a patient, and each square is the stage in the emergency room, and the color is the priority of the patient. And you see how long and in real time where the patient is in the emergency room and where he is going and so on. So these kind of things can be very useful for policymakers, but also for research. And then you can do that without really needing to manually collect data. So those were 2 examples for two examples. And now where we are in the process of is to deploy in more jurisdictions. So we are deploying across Canada some hubs, and we are now working with France and Germany and other data science research group. Right now we are still at the data science stage where we try and investigate what are the limits of these technologies and strategies. But as I said, next steps. So the next step, so we are going to undertake in the coming weeks independent privacy and security audit. We want to add a public engagement layer. Right now, we really focus on the technology, but we are, as we speak, working with specialists in public engagement to involve patients and families and the community into the platform so they can provide direct consent for more advanced data sharing or not, or withdraw if they want. We are working into expanding toward other settings and other data types such as transplantation, blood transfusion, and government agencies. Of course, working on validation. This will be forever. The data, as you know, is when you think that your data feed is good that you realize that it's not. So forever validation. Of course, sustainable funding. But so the next steps are infinite, but I think that the possibilities are also infinite. So if I have time, I have 2 or 3 analyses that I could show you. Aminat, do you want me to show you example of analysis we did, or? Yes, okay. So this is the first analysis done in fact, it was the first one we did just to test everything. So I don't know if you know this paper by Gattinani in the early pandemic, where they realized that ARDS, COVID ARDS had some sort of phenotype, the L and the H initially. Not sure that these phenotypes are used anymore, but we were curious to see if we were seeing these phenotypes across sites. So the answer was no. We did not see any clustering of these phenotypes depending on ventilators, settings, compliance, and PAF ratio, or any other type. So I did not show this slide yet. Didn't show this slide because it was not interesting. It was just a blur. But what we also did is correlate the intensity of the PF ratio on raw images and see if we saw a correlation with the level of whiteness and the PF ratio. And here you see the results. So I know it's not rocket science. It's obvious that the wider the lung, the worse the PF ratio would be. But what is interesting is that we did it in a federated manner without direct data access. We did some more advanced phenotypic analysis where we just threw a bunch of variables in the system with demographics, comorbidities, vital signs, lab drugs, raw images of the chest X-rays, ventilation. We did run remotely some imputation of missing data when needed. Ended up with 111 candidate variables. So this project was done by a postdoctoral fellow, and we obtained the obvious result that so the red you have ICU patients, green you have I forgot green and yellow which one is discharged and which one is admitted patients. But what you see is a determinant for admission. The characteristics of patients at baseline that were admitted to the ICU had a worse FiO2, worse creatinine level, worse white blood cell, worse platinum, lower hemoglobin, higher age, more chest opacity. So it's not counted by clinicians, but really by raw extraction from images, and so on. So just to use the plausibility of what we can do with the data with this kind of platform. Dr. Cadrin Chainevert, who's a data scientist, is currently training an opacity identification model. He also, by the way, won a Kaggle competition with that, where we're using this pipeline. We find the chest X-rays, and then we can count or estimate the level of opacity on chest X-rays without human intervention. Some principal component analysis. So for those who know what it is, so just so you can really try to explain the predictors for clinical outcome. I will skip these for the sake of time. But we also open the platform for basic analytics research. For the mathematician in the room, I apologize. This one is from one computer science student, so I cannot answer all the details, but he worked on the platform on developing new imputation techniques that would be more automated and at least as valid as the commonly used Monte Carlo techniques to find the best multivariate distribution for imputing missing data. So he used what we call GAN, the generalized adversarial network, generative adversarial network, sorry, in English, where he literally made two models, and sorry if I'm too basic here, but literally fight one against each other. So one model is trying to it presents data to a second model, and the second model tries to bet if it's true data or false data. And then the first model is the one trying to generate a fake data set that the second model cannot discriminate with the real data. So and then I show you some interesting results. For example, here with labs. And again, this kind of project is possible only if you have hundreds of thousands of patients and an infinite amount of data to validate yourself and train your model. But we have very interesting results here where you see the green line is the observed distribution of your data. The orange line is the usual multiple imputation by chain equation method, and the blue line is our fine GAN, so the generative virtual network results. That kind of fits the data, that seems to fit the data a bit better than the mice model. I would not consider it's better because we have examples that it's not, but at least it's kind of simple and useful when you want to implement this remotely. Again, this is research, but these kind of large data infrastructure allows you to do this kind of basic research. So I stop there. So key messages for today. I went through the needs. I went through what we are trying to deploy and hope to collaborate with more and more people to deploy this kind of technology that enables data sharing and analytics at a large scale. But more importantly, why we're doing that, because of the key message that I conclude my talk with. Honestly, AI had a limited effect on bedside care during COVID-19 pandemic. People said, well, it should have helped, or it could help, or it may help, and so on, but it did not. So why is that? We think that for it to be useful in the future, it requires standards for integrating data from disparate sources and software that are already implemented, and more importantly, real time with real world data that is not overly curated and does not represent real life. We need variation, a lot of source, and we need to listen to what people care, what the patients care, and what the policymaker care about. So we have to go through different institutions, different policies, different resources, expertise, and so on. So we can hope for these models to one day generalize well across jurisdiction, countries, and different patient populations. And now it's important that we engage everyone. So not the AI researchers in one side, the healthcare providers on one side, and then the ethicists at the university saying that all the other ones are doing things not the correct way. We need to sit together and build things together so we are ready the next time. And if there's no next time, so we can at least implement better care at the bedside and implement them within existing workflow of patient care. Thank you. And I take your question.
Thanks, Michaël. Sorry. Is there any questions? I can see some of the questions on the chat.
Yeah, so I can take a few questions in the chat. So do you control for what variant of SARS-CoV-2 each patient has tested or been treated for? Control in a statistical term, we can if you specify your model that way. Absolutely, we do have all the SARS-CoV-2 positive, negative, and we don't do the sequencing for every patient, but when it's done, we have it. Do you track data of what treatment protocols or therapeutic each patient received? So again, how it's done is we have a raw data. So we have access to the raw pharmacy system of all these centers. So then it's up to the researcher to frame the question correctly to extract the treatment they are looking for. It can be all the treatment, and then create their analytic plan to test this question. Also, do you track pre-existing condition, age, and other medical history? Yes, we do track the whole EMR. That's the goal of this. We have all the medical history of the patient into the network. Hence, the very high level of privacy and legal and careful management of this strategy.
All right, Ian would like to ask a question.
Thanks, Emma. Hi, thanks for the talk. It was great. So early on in your talk, you mentioned you were interested in sort of maybe putting patients into subgroups, depending on maybe something like the severity of their disease or something to do with that. So maybe you could treat them differently. Did you manage to do that? I was wondering how that went.
Yeah. So right now, so we are still at the stage. So we do have several analyses that have been completed, and we are writing the papers for that. So we have a white paper on the platform, a white paper to describe the population, and we are working on the phenotypes that I showed right now and putting it together for publication. Now, if your question is, do we have, can we make subgroups? Yes. Did we do in-depth analytics for each subgroup yet? No. We're working on that's the goal of this. We are at the stage now where we can do that. And what I did not mention is what is also very interesting to me as a clinician scientist is we are putting a clinical trial layer on top of it right now. So we can do automated clinical trials to target specific population and screen for specific population.
Right. So were you treating patients differently who came into different subgroups, or was that still research level?
It's all research level.
Yeah.
This being said, we do have the Ministry of Health who requested us some stratified analytics. And we are working, we have a $600K project, $600,000 Canadian project with them to work on that, so specific risk indicators for at-risk patients and so on at the policy making level. But at the research level, this is exactly what we're working on. I don't want to, I don't want to spoil my colleagues' work, but we have people working on immunocompromised patients subgroups, HIV. So we are downtown Montreal, so HIV and highly immunocompromised patients, co-infections. So that's what we're working on as we speak.
Sounds great. Thanks.
And we are a transplant center too, so the transplant patients are a cohort that we focus on quite a bit.
Thank you.
Any other questions from the audience? Yeah, I guess no.
I see two right hand. Jan Wood, probably the old end, and Yannis.
Yeah.
I applaud you for keeping it keeping it like as open source, and I assume that's also for the coding or just for the data.
Okay, good question. Sorry, I was not clear on that. So the data is not open source. Okay. Because it's literally the whole EMR of a 4.5 million population. So in fact, I don't have access myself to the data, except for my own patients. So it's federated, and each site is the fiduciary of its own data and responsible for quality control, validation, and the red zone I mentioned. Each site is responsible for this zone. So we are responsible of managing the rest. However, what is open source is the code to do that. So how to manage this kind of source data, the site API, the learning API, the federated. Well, the federated API is not online yet, but learning API, sorry, but coming. So we hope that by doing that, other people will. So right now, the only thing available are not open source, are private industry and so on. But we hope that by making these kind of technologies open source, we'll have other groups starting working on similar strategies. So one day, maybe we can connect several jurisdictions, countries, and do this kind of analytics.
Okay, now here is where my question really lies. The open source is great. However, do you have a system to track that people do not use the open source, like basically all the service and the know-how that you are developing, and then they monetize? Do you have a system to actually track? So if anybody monetizes, that at least they go back and they fund you and your initiative.
I did not expect to go in that direction today. So this is a very interesting question. It's a philosophical question also. So right now we use the global public license, the GPL license. So meaning that we do have a license on everything. So another entity could not just take everything, license it, and prevent us from using our own work. I'm an academician. I work in a university. I don't want to create a company. So I'm happy with the open source strategy. Now, how can we sustain all of this? For now, we're going through grants and research grants and the government supporting us. I think that if you need a business advice, in fact, regarding this, I would be probably the worst person to talk to. So the short answer, I cannot answer that because I'm very bad at this. My university is looking into this, and they are a bit thinking on what to do with me putting everything online. But yeah, that's maybe what I can say about that. But right now, how we sustain ourselves is really by the know-how. So people around us in our jurisdiction go to us to ask us to help with projects. And we work in a cost recovery model where literally people just pay the time it takes to adapt things. If they want to implement their own things with their own budget, be my guest, feel free to do so. And then we work with research grants. So now we want to study this group. We go to the government agency or funding agency, and then we compete for the little money that is available for research.
All right, thank you. We could squeeze through one more question if there is one. All right, I guess that's it.
So if there's no more question, if you have questions I'd like to discuss offline, or if you'd like to know more or any other kind of collaborations, please feel free to contact me. My email address is in the button there, and I really thank you for the opportunity to talk to you this morning. Thank you.
All right, thank you very much, Michael. And on behalf of everyone, I'd like to thank and appreciate your time with us. Okay, thank you.
Thank you very much. Good night.
Bye.